We're going to try and get started on time. And welcome back from, that was a truly wonderful lunch. Usually you don't get, you usually have that dried chicken stuff, but this was good chicken. Anyway, thank you all for coming back for this afternoon session, which we hope will be equally stimulating to this morning's session. And today I'm going to introduce the moderator and principal case presenter for our next part of the program, which is Controversies in HIV Management, which will be a case-based discussion. And I invite all of you to also participate. So Dr. Gandhi will be asking the panelists questions, but if you have points you'd like to make too, please come to the microphone. We enjoy the interaction if you can do that. So let me introduce Dr. Raj Gandhi, who's a professor of medicine at Harvard Medical School and the co-director and principal investigator of the Harvard Center for AIDS Research. He's also the director of HIV clinical services and education at Massachusetts General Hospital and is the site leader for the MGH clinical research site of the AIDS clinic. It's no longer called Advancing Clinical Therapeutics Group, ACTG, and now is the vice chair of the ACTG and the vice chair of the Infectious Disease Society of America COVID-19 treatment guidelines panels and the chair of the IAS-USA antiretroviral therapy guidelines panels. He's an editor-in-chief for the New England Journal Watch Infectious Diseases. And I think I'm going to stop there because it's too long to read. So you guys need more time for his case presentations and questions. So thank you, Dr. Gandhi.
Thank you. That's great to be here. I'm looking forward to interacting with all of you. As Dr. Benson said, please do ask questions, make comments. We have an hour of time and then another 15 minutes of Q&A. And these are patients that I've seen over the last couple of years that I think really bring up some interesting management points. So let's go ahead and get started. Here are our learning objectives. So we have some one to start questions, some issues around long acting, and then some issues around cardiometabolic. So we'll start with the first case. This is a 50-year-old woman with HIV. Her CD4 count is 20. Her viral load is 500,000. She comes in with fever and headache. She's not on antiretroviral therapy, and she's diagnosed with cryptococcal meningitis. She started on treatment for her cryptococcal meningitis. We can touch on this in a minute in terms of options, but liposomal amphotericin plus 5-FC, standard treatment. And the question is, when should she be started on antiretroviral therapy? So we're going to ask you to go ahead and vote, as you've been doing all day. Should you start her antiretroviral therapy at the same time as her antifungal therapy? Should you wait about 4 weeks? Should you wait about 6 months? Or should you get her through her induction and her maintenance and then start antiretroviral therapy? So let's see what you all think. And then we'll put our panel on the spot. And I'm probably going to ask Dr. Benson to take this one, because this is truly a controversy. So let's see what we all think here. So most of us in this room are thinking about 4 weeks, and then a smaller percentage are saying concurrent with antifungal therapy. So what are your thoughts, Dr. Benson?
So this is a question that has come up numerous times over the years, and the principal recommendations about starting antiretroviral therapy probably will begin the saga with a randomized clinical trial that was done not in the United States, but in a resource-limited setting in Southeast Asia, that demonstrated starting antiretroviral therapy early, and that was within about 2 weeks of starting antifungal therapy, was associated with a higher rate of adverse reactions and mortality than compared to starting later. That led to very strict guidelines about starting therapy after completion of the intensive phase of antifungal therapy and a little bit more into the 8 weeks after starting antifungal therapy. We've been trying to push that guidance further now in all of our guidelines recommendations, because I think the study itself was done in a resource constrained setting that didn't have access to some of the therapies that we intervene with in both monitoring antifungal therapy and in dealing with the adverse effects of cryptococcal meningitis on CNS pressures, and also took place before we had data on prevention of iris, which is one of the things that people were most worried about. It also took place in a time when we didn't have the same antiretroviral therapies we do now. So with the advent of more effective antiretroviral therapy that you can start earlier, the treatment with corticosteroids and for prevention of iris, and some of the more intensive monitoring and interventions that we use for support of cryptococcal meningitis, at least in developed areas that have access to all of those interventions, we currently recommend starting antiretroviral therapy within 4 weeks. And many in our IAS-USA guidelines, we talk about 2 to 4 weeks. And that is based on all of the things that I just said. But in addition, the fact that in people who delay antiretroviral therapy, there's a higher risk of developing another opportunistic infection, and there's a higher risk of problems with continuing the antifungal therapy in people who don't start ART and get a good response. But the real key here is having a reasonable clinical response to antifungal therapy. So if you can demonstrate that the fever is responding, the CSF white cell count is responding, they're having a clinical response to antifungal therapy, you can probably start antiretroviral therapy much earlier than we did in the past.
Yeah, and I'd really like to underline that point. I think that last point is so key. As soon as they have a clinical and CSF response, I think that's a good time. Any other additional comments beyond what's already been made?
Yeah, I mean, it's one of these things, like it's either too early or too late.
Yeah.
And I think it is, this 4 weeks is a guidance, but it really is clinical judgment that you need to use. And I think, as Connie so eloquently stated, really looking at how the patient's doing to make that decision.
Terrific. All right. Let's go ahead and push on. These are the points that were already made. Liposomal amphotericin plus 5-FC is the mainstay. There is a really interesting regimen of high-dose liposomal amphotericin followed by fluconazole plus 5-FC that has good support. We'll see where the US guidelines take that, but the WHO has promoted this as a preferred regimen. This is the essence of management. I won't belabor this because I think most of you will have some experience, lumbar punctures at day 7 and 14. This is the key point, though, that an effective therapy is defined as clinical improvement in a negative CSF culture, but not necessarily a negative cryptococcal antigen. In fact, the guidelines are clear that we should not be monitoring cryptococcal antigens because they can be quite misleading. And then the last point is the most important: management of intracranial pressure. This is the ambition regimen. I won't go into detail here, but something that I think is getting greater and greater use. And then this is the COAT study that Dr. Benson alluded to. This was a study that raised some question about early antiretroviral therapy, but was done at a time and in a place where management of intracranial pressure was not as successful as it is now. And so that's where the IAS-USA has come down. If you'd like to read more, do spend some time and take a look at that particular section of the ISA-USA guidelines. These are from about a year ago, but are still quite current. All right, let's move to it completely. Dr. Johnson, you want to?
I just want to make one other point about cryptococcal disease. Is the OI guidelines actually recommend screening for asymptomatic people with advanced disease, CD4 less than 200, but especially CD4 less than 50, because there is a finite rate of positivity. And I just mentioned it because I think that's a guideline that's infrequently followed sometimes.
Very, very good point. I had a patient last week who had a CD4 count less than 100. And
you
even
actually
if
reminded me of
asymptomatic,
another point about
why don't we
that,
finish up
is
with this?
that there are at least 2, maybe a third randomized clinical trial now that has shown that preemptive therapy in the setting of screening for asymptomatic cryptococcal meningitis can prevent cryptococcal meningitis and improves mortality. So I think, as you said, it's not something that's frequently adopted in our part of the world, but it's something that's highly recommended in places where we see a lot more cryptococcal meningitis.
Terrific. We will definitely have time for questions or comments, but if you do have a question or comment, you're welcome to come to the microphone and save your questions, maybe bookmark them for the end, because we have set aside time for that. All right, so we're going to shift gears completely and talk about pregnancy. So this is a 35-year-old woman with HIV. She's on bictegravir FTC TAF. She's virologically suppressed. Her CD4 count is fine. Her pregnancy test is positive, and when evaluated, she's at the end of her first trimester. So she asks you as her clinician 2 questions. First, what regimen is safest for me and my baby? And she asks, can I switch to the shot, cabotegravir rilpivirine, like my partner? So what do you recommend to your patient? Would you recommend dolutegravir plus TAF FTC? That is switch her off of bictegravir FTC TAF because the first is the preferred regimen? Or do you recommend bictegravir FTC TAF continue? Or do you recommend switching her to the shot, cabotegravir rilpivirine? How about switching her to boosted darunavir, ritonavir boosted darunavir plus TDF FTC, or something else? And you'll have to tell us what that something else is if you vote for it. So go ahead and vote. Let me voting very quickly. So we have 52 votes already. Great. Let's get up to 60 or 65, and then we'll see what our panel thinks. We were talking about Abby yesterday. All right, let's see what our panel thinks. Let's see what you think first, and then we'll see what our panel thinks. So take it away. Okay, so about 7 of 10 of you like continue bictegravir FTC TAF. 1 in 7 or so are willing to switch to cabotegravir rilpivirine, and then an equal number prefer dolutegravir TAF FTC. What does our panel think?
And so bictegravir, first of all, perinatal guidelines were updated in the last year, and bictegravir, which previously had been an alternative, has now been restored or placed in the preferred category. So that's important here. So she actually is on a preferred regimen right now. The other point that the perinatal guidelines make is that if a woman is on a regimen and doing well and becomes pregnant, it's perfectly acceptable to continue that regimen during pregnancy. So I agree with the 3/4 of people that said that.
What does the panel think about cabotegravir rilpivirine?
Yeah, I can comment. I mean, if you think this pregnant person is an adult with HIV that's virally suppressed, and we have seen stable switch be effective, but we don't yet have enough data on the PK of Cabril in pregnancy, but attempts to try to get that data, and there are some studies going on. I think I would ask why she wants to switch, because if the issue is that she's concerned about really taking her pills every day or worried about whatever, I would be very interested in what the reason was. But I think I would hold off unless there was a really compelling reason, just because we don't have as much PK data as we should have. We should have at this point.
Should have, yeah.
And just to add, the perinatal guidelines do say to be cautious about any 2-drug regimen, including rilpivirine, but also dolutegravir 3-TC. Experience in pregnancy, just not enough to recommend it routinely.
Any additional comments?
Unless they're on it.
Yeah.
And
if
that's
they're
because
on
I
it,
actually
maybe let's explore that for a minute. If you have a person on dolutegravir 3-TC and they're happy with it, how do you advise them if they're on a 2-drug regimen when they become pregnant?
Yeah, the guidelines say support the woman to continue taking what she's taking.
But maybe with a little bit more frequent monitoring, or at least discussing of that. Yeah.
Correct.
Yeah. So I think we hit the highlights. These are the June 12, 2025 DHHS guidelines, so relatively new. As heard, dolutegravir TAF FTC and TDF if TAF is not available are preferred, but now what's been promoted as of June is bictegravir FTC TAF. I'll show you one slide on the data that led to that promotion. Alternatives are listed here, boosted darunavir given twice a day, and that's with TDF or TAF, and then abacavir is considered an alternative, not a preferred. It's only in this one instance that we go to a protease inhibitor. If a person has acquired HIV while on cabotegravir for PrEP, there's enough uncertainty about integrase resistance that then ritonavir boosted darunavir is considered the safest regimen. And this is in part because the stakes are very high, of course, during pregnancy for the woman and for the infant. These are the data that they took into account when they promoted bictegravir FTC-TAF. First, there's really no safety concerns from a variety of different sources, one of which is the antiretroviral pregnancy registry. Admittedly, that's a passive surveillance kind of registry, but nevertheless shows no evidence of excess birth defects with bictegravir FTC-TAF. And then the PK, such a critical point about PK during pregnancy. These two studies essentially show that although levels of bictegravir are lower during pregnancy, they're still high enough to inhibit viral replication. That's the take home from the impact study and the manufacturer-sponsored study, which are the two studies here. What about injectable cabotegravir rilpivirine during pregnancy? We don't know enough, basically. It's not recommended, as you heard, during pregnancy because of some concerns around the PK, in particular around rilpivirine, although some of this is based on case report kind of data. Well, Bill Short at Penn presented a case series of 23 pregnancies in the US where during pregnancy, the woman was on cabotegravir rilpivirine. Of those 23, 17 were on Cabril before pregnancy. 13 individuals stayed on Cabril. You see the outcomes were virologic suppression in 92%. 6 people switched to Cabril during pregnancy, and 83% of them were virologically suppressed. In terms of the outcomes for the infant, there were 21 live births, 1 miscarriage, 1 stillbirth, and no infant transmissions. But I think the bottom line is literally the bottom line here, which is the last bullet. Because of that concern around PK, because of uncertainty about efficacy, this is really not something we would recommend, again, because the stakes are very, very high. I had heard, and maybe someone can comment, that Impact was going to do a study of drug levels, but then when I looked on their website recently, it had been disrupted by some of the many other disruptions that are going on. So I don't know if anyone knows whether we will have data soon on this topic. Do you know?
There is a study that was funded in Europe that's being done, I think in South Africa, that's going to be looking at this. But one of the issues was availability of the drug in some countries and making it available that upended some of those efforts.
Yeah. All the more reason that we need to.
Just one other point, and maybe you were going to make this about the darunavir. You emphasize it's twice daily darunavir and not with cobicistat, because that is gives low levels in pregnancy.
Yeah, good point.
So if someone is on rilpivirine and becomes pregnant, you would support them in staying on it, or you would switch them?
I think it would go back to that same question about what is their reason for being on it. Is it something that they prefer, but during the period of pregnancy, they could take a pill where we just have much more data, or is it really impossible for them to take a pill?
And I've supported women through
really
pregnancy.
Let's see what
I've supported women in pregnancy who are on cabotegravir preconception and then became pregnant. And what we did was like monthly or every 6 week viral loads, and which matched nicely with their MFM appointment. So it was like every MFM appointment, they got a viral load done. And again, my N of like 6 did fine, but I understand the data shows that there is still some vulnerability there.
Thank you for jumping in. That's great. So you've had experience in that very situation, and that's what you've done. Good, perfect. Any other comments? Good question. All right. Speaking of adherence, we're going to switch gears now to talk about a 50-year-old man with HIV who was diagnosed in the 1990s. At that time, he was on efavirenz FTC-TDF. He does have a previous HIV genotype showing a K103N, the signature mutation that causes efavirenz resistance. No other mutations are known. His surface antigen and core antibody are negative. His surface antibody is negative, so no exposure to hepatitis B in the past. He's having difficulty remembering to take oral antiretrovirals, but his CD4 count now is 500 and his viral load is 20,000. And he asks you about cabotegravir. So let's go ahead and vote. For this person, would you recommend treatment with injectable cabotegravir? Go ahead and vote. And this one, I'm guessing there's going to be a variety of different perspectives. So okay, about 52 people, 58 already. What happened to our music? Okay, 60, 62. Good. I think we'll see what you all think. Okay, yeah, as expected. So 50% say yes, 30 or so percent say it depends. And I think that's right. And then 20% say no. So yeah, let's see, Dr. Johnson.
Yeah, I say no, just because in Colorado, we have not done any cabrolpivirine treatment in viremic individuals. We've not been able to use it outside of its typical use as a switch strategy. The other issue, of course, is addressing the hepatitis B issue. And I probably want to address that first. Just because cabrolpivirine is not effective against hepatitis B. So I think I would, I would stay the course or try oral therapy just because we can't use it in virulent folks.
Yeah, and hold the thought about hepatitis B. The next case, we're going to explore that in more depth about hepatitis B. But any other thoughts? And I neglected to introduce Dr. Johnson and Dr. Gulick, just so I'll take a pause here. Dr. Johnson, waving his hand, is from the University of Colorado and is going to be speaking later in the afternoon. And Dr. Gulick from Cornell is our closer for today, and he'll be speaking as well. So comments?
Yeah, I was going to say, I was going to vote for the it depends people. The other issue here is resistance, of course. What we heard is that he has a K103N on a prior genotype, and he's on efavirenz now. One striking thing about that is that he doesn't have the M184V, so it makes you wonder about that previous test result, and do we have everything we need? K103N alone is not enough to knock off rilpivirine, but if he had any other NNRTI mutations, you might be concerned. And we know, looking back at the prospective studies of this regimen, that the number one factor for failure that was associated with failure was NNRTI resistance, significant. Again, if it's just the 103N and we believe that, then it's okay. But is there something that we're missing here? And so I would want to see if there's any possibility we could find out more about his resistance profile.
One more comment.
Yeah, I will say I'm probably on the it depends, but leaning more towards yes in this kind of situation. I feel like if we see folks struggling with oral adherence, trying to continue another oral medication is likely not going to be effective. And so he's coming to you motivated to think about injectable. I think it's important to talk about the pros and cons. And I agree. I think I am concerned there might be more NNRTI resistance hidden in previous genotypes, but I think there is a good amount of data to support initiation of cabrolpivirine in people with viremia, certainly less than 100,000 like this case. And I think with some shared decision making, and if this is something he truly wants to embark on, I would totally be okay with it. Some individuals, even with K103N and this concern for NNRTI past failure, may opt for monthly dosing for the first several months. I know Ward 86 opted for this kind of sort of hybrid kind of model for a bit of time before moving to the every 2 months. So that's another sort of middle ground you might be able to sleep better at night thinking about as a clinical option.
In Illinois, will Medicaid cover access to cabrolpivirine with viremia?
So we have not, we've been able to get cabrolpivirine for people with viremia. We don't make a big noise that they are viremic when we are asking for medication, but at both University of Chicago and Howard Brown have. And I'll plug the Crown study, which is currently looking specifically trying to answer this question for people with viremia between 1,000 and 100,000. We're waiting for those results once it's fully enrolled.
Let me take the pulse of the room. How many people have patients who they've treated with cabrolpivirine during viremia? It's like a growing number, not exactly half, but maybe a third or so. So good proportion. Was someone else going to make a comment?
I was going to add that I believe we have treated viremic patients at Colorado. We have treated viremic patients at Colorado, and I raised my hand, but I would still be in the it depends crowd. Just because I'd want to know more about the reason for non-adherence. Like, is this person going to be able to continue coming to the clinic, especially if we're in a more spread out area where transportation is going to be difficult, which is sort of one of the adherence issues we see. So I'd really want to explore that adherence difficulty in a lot more detail before making a switch.
Let me take one.
Also, just to point out the latitude study, which was in people that had prior failure, who went on an oral regimen and then switched, randomized to stay or switch. 17% of them, I think, were viremic at the time they started, even though they were suppressed prior to that. So, I mean, we have a really good growing body of data about the efficacy. I think that it wouldn't be the viremia that would worry me. It'd be more this issue of making sure we know about its resistance.
Last comment.
Just to add.
This is great. Everyone's commented. So
Yeah.
Everybody has a comment.
Yeah.
So,
This is a
so
sharp elbow group.
no,
up here, so.
I was going
I
to
will
try to
yield to the
involve
chair.
our geriatrician a little bit more here, but because we didn't discuss this at length in your talk, but with the declining muscle mass and the changes in renal function over time in aging people, do you have concerns about some of the injectables when treating people who are older? You made all of your cases
I-
50, just
I was going to
to
say, I think.
hedge your
when you say
bets
older,
there.
I take exception to that, but let's go ahead. This is the last point. I think we can
Not
move on.
particularly high concern. You're sort of balancing the less volume of distribution, but also decreased renal clearance, which is still how cabotegravir is cleared. So it probably evens out in the end. There haven't been any signals that low muscle mass folks are going to suffer any consequences for that. They should still be as effective.
Let me just say, we need a better regimen for people with
Yes.
NNRTI resistance. And so the one that's emerging, of course, is cabotegravir lenacapavir.
Exactly.
And so that would not be an issue for this guy.
Yeah.
So
We don't have a
let's-
lot of experience with this. It's
Yeah.
more anecdotal so far.
Let's pick up on that. So these are the indications: the FDA approval for long-acting cabotegravir, rilpivirine, no history of treatment failure, no known or suspected resistance to cabotegravir or rilpivirine, and virologic suppression. We know it can be dosed every 2 months, although many of us will start with every 1 month, and then it's in the gluteus medius in the clinical setting. I won't belabor this, but this was the study. Atlas and Flare and Atlas 2M were the phase 3 studies that got this approved. When you look at risk factors for virologic failure, as was said, rilpivirine resistance mutations leads the list. These are detected by proviral genotyping, a topic that has its own set of controversies, but we'll come back to in a separate case. If you've got 2 or more risk factors, obesity, rilpivirine resistance, and subtype A6, which is a bit more common in Eastern Europe, that's when you get really high rates of virologic failure. If you have 0 or 1, you have rates around 0 to 2%. The Latitude study was mentioned. This study will be published soon, but this is a study looking at people who have difficulties with adherence. They were randomized to receive oral standard of care with conditional economic incentives, financial incentives, until they were virologically suppressed, although not everyone got to below 200. And then they were randomized to injectables monthly or continuing oral therapy. And essentially all of the 3 endpoints, regimen failure, virologic failure, and treatment-related failure, kind of pointed in the same direction, favoring the injectable. I don't have a slide on this, but the Impala study was presented in Kigali, Rwanda this year, done in sub-Saharan Africa, similar design as Latitude, that is, people first became suppressed and then got randomized to oral therapy or injectable rilpivirine. It didn't show superior results, but showed very high rates of virologic suppression, both with injectables and with oral therapy. Here are some of the data that pertain to treating with rilpivirine during viremia. San Francisco Ward 86, 129 people. The viral load mean was about 45,000. CD4 count was below 200 and 50%. And at week 48, 98% of those individuals stayed suppressed. 5 of them had gone back to oral ART. A study that I think is not that informative, the OPERA database presented in Kigali. This looked at 368 people, but here viremia could be as low. In fact, the median viral load here was only 120 copies. This was a kind of a database study. They showed high rates of virologic suppression, but these people were almost suppressed already. And then a notable study from a few years ago from Mississippi, 12 individuals, all of whom got rilpivirine, but here they started with a very, very high viral load, and they stayed suppressed, although the follow-up was as little as 1 month or as much as 17 months when it was published. This is my own take. I think all of these points have been hit, and actually I brought this case purposely because it really there's a lot of considerations here. For someone who's virologically suppressed already and doesn't have known resistance, of course, this is a very good regimen. The vast majority will stay virologically suppressed with capivasertib. That's why it's been approved. I do counsel people that there is about a 1 to 2% rate of virologic failure and resistance, but if it's preferred for what works best for them, this is clearly a good regimen. For people with a history of NNRTI mutation, especially in this case, his CD4 count was 500. His viral load was about 20,000. I usually will start or at least discuss a different regimen first if they're able to take oral ART because of that concern that several panelists raised about these low-level rilpivirine resistance mutations and some reports of virologic failure. So K103N was acceptable in the Atlas and FLAIR studies, but in these 1,600 people who were in these studies, about 20 or so had K103N. So it wasn't exclusionary, but there weren't that many people. All those 20 people did well, but it's a small sample. This last point was made, but we essentially need studies of cabotegravir, lenacapavir, the ACTG, I think in short order is finally in a place to launch a study here in the United States called the PALACE study, which is looking at cabotegravir, rilpivirine in people with NNRTI resistance. And then a similar study is a little further behind. Hopefully will happen in 2026 in sub-Saharan Africa or other parts of the low and middle income country world called Lancet. This is for someone who's viremic, if their CD4 count is less than 200 though, the IAS-USA, the DHHS do recommend considering that on a case-by-case basis, but it's not the drug as it's the drug with addressing the barriers to engagement and care. That makes all the difference. So I promised you a case of someone with antibody positive core, so hepatitis B exposure. So let's see what you all think about this patient. So you're right, they're all 50, aren't they? A 50-year-old man with HIV. They're all young. This person, though, unlike the other person was core negative. This person is surface antigen negative, and that's a typo. So it's surface antigen negative. Let me clarify. Core positive, surface antibody negative. So he's isolated core positive, which means we think that he might have had exposure to hepatitis B in the past. Some years ago, he got the alum vaccine, the Engerex vaccine, and never got a seroprotective response. His surface antibody stayed below 10. His CD4 count's 500, his viral load is suppressed, and he asks you about switching to cabotegravir rilpivirine, so stopping the tenofovir part of his regimen. So I didn't put this, but he's on tenofovir FTC. He's on TAF FTC bictegravir. So this is going to be a two-part question. So we're going to kind of do these in rapid succession. So first, I'm going to ask you, what do you recommend? And then I'm going to ask you about dosing of hepatitis B vaccine. So the first question, what do you recommend? Do you recommend that this person is core positive, virologically suppressed, wants to switch off a tenofovir containing regimen? Do you recommend to go ahead and switch? Do you recommend to retry with the alum vaccine and give that a shot and then switch to cabotegravir? Use a new vaccine, the CpG adjuvanted vaccine, so the Heplosev vaccine, then switch to cabotegravir. Do a vaccine series with the CpG adjuvanted vaccine, but only switch him if he gets a surface antibody response of 10 or more, a seroprotective response. Or don't switch regardless, just tell them it's too high of a risk. So what do you all think? What I think I'm going to do is I'm going to ask you this question and then a follow-on, and then I'll have our panel try to keep both these questions in mind and address both of them. So switch, and then if you're going to vaccinate him, I'm going to ask you how many doses of vaccine you give. That's the question that comes. And Dr. Johnson is going to talk about all of this in much more detail around vaccine. So let's say, what are those? Stay tuned kind of things. So you're going to get more on this really important topic. So let's see what you all think. Okay, so about two-thirds of you say vaccinate him and only switch him if he gets a seroprotective response. That's interesting. We'll come back to that. Second choice was give the vaccine, switch. And then the third option, interestingly, is don't switch at all. So, okay, trying to think how to do this. Let's take, so that's the first question. Actually, I'm going to change my mind. Let's see what our panel thinks in terms of this specific question, and then we'll explore how many vaccine doses to give. So what does our panel think about switching someone with isolated hepatitis B core to a non-tenofovir containing regimen? Looks like Dr. Johnson's leading in.
Yeah, Well, I mean, one of the things about tenofovir containing regimens, obviously, if they have activity against hepatitis B, and actually in non-immune folks, it tends to act like a PrEP agent in a way against hepatitis B. So there have been studies that show that acquisition of hepatitis B is less frequent if patients are on tenofovir containing antiretroviral regimens than on other regimens. Now, in this setting, you have an isolated core antibody, and there's kind of a differential diagnosis. Probably the most common is remote infection, and you just kind of lost the other antibodies. And you're obviously going to evaluate that with vaccination. But, you know, I agree actually with the majority of the audience that I would use this new, more effective vaccine and try to kind of generate immunity before switching.
Maybe one more comment? Yeah.
Yeah, there was a great debate at ID Week this year about how to manage these patients with isolated core. And to me, isolated core antibody is like the Krebs cycle, coagulation. I was just like, what is that? It's so confusing. And, you know, it could be a false positive is the other thing, right? And so getting, you know, one of the points that was made in that debate is making sure the hepatitis B, like all these studies that have looked at people switching with a variety of combinations of hepatitis serology, they don't all do all the tests, but if it's only core without surface antigen, it does appear that the risk is low. And you're going to get into this more of what is the strategy to vaccinate. But I feel like the data is really starting to emerge that you have to characterize what this immunity is. You have to vaccinate, but then you will be able to proceed as long as there's surface antigen and DNA negative.
I agree with that. I will parenthetically say there's this funny meme that's called the real Krebs cycle. And the real Krebs cycle is learn the Krebs cycle, forget the Krebs cycle. Learn the Krebs cycle, forget the Krebs cycle. So that's the Krebs cycle. So,
Yeah.
okay. So if you're going to vaccinate him, let's do this quickly. Same patient. If you're going to vaccinate him, how many doses of the Hepliceb CpG adjuvanted vaccine are you going to give? So are you going to give one dose? He was previously vaccinated. Are you going to give 2 doses? Are you going to give 3 doses, or he doesn't need to be vaccinated? Let's see what you think. And here I'm going to take us up to about 50 something and see what you all think. And I'll probably ask the panel to be pretty brief because Dr. Johnson's going to explore this, and I want to get to some of these other issues. Okay, so 2 doses, and some of you want to give 3, and some of you want to give 1. Okay, Dr. Johnson is going to enlighten us, but maybe one of you wants to say what you would do.
Supposed to give 1 dose and see how they respond. It's like a probe, right? To see if they have prior immunity that's being enhanced. But
yeah, that's the guidelines currently say that if you have isolated core antibody, you give a single dose, and then you measure the titer. And if the titer is really high, like greater than 100, then you're done. If it's not greater than 100, then you complete a 2-dose series. And with Hepliceb, this vaccine.
Great. Okay. We'll come back to that later in the afternoon where you're going to see some of this data, I think. I wanted to just mention 2 recently presented studies. These are from ID Week and the European, the EACTS meeting. So one is from the Swiss HIV cohort, a very well-characterized cohort. This is looking at what happens with hepatitis B reactivation after stopping tenofovir. This was 967 people who were surface antigen negative, core antibody positive, so who switched off of tenofovir containing regimens. Prior to switching off of tenofovir, the detectable hepatitis B DNA rate was about 1.4%. After 1 year, the rate after switching was about 3.9%, but all of them were below the quantification limits. And when they looked at elevated AST, about 30% who had a detectable Hep B DNA, all at low levels, had an elevated AST, and about 20% without a detectable hepatitis B and had an elevated AST, and this was non-significantly different. A separate cohort, and from Barcelona, this was that issue of not characterizing people as well. 741 people who switched to cabrilpivirine, no hepatitis B reactivations among surface antigen negative people, including some with isolated core. So someone I work with came up with this really nice schematic. So these are the 3 tenofovir sparing regimens that are commonly used: cabrilpivirine, dolutegravir, rilpivirine, somewhat less used, dolutegravir 3-TC. So scenario one is that this is my own thinking, and you'll get some differences in this. But if they're non-immune or infected, including if they're isolated core, I would vaccinate and measure a surface antibody response. And then if they have ongoing exposures, if they achieve a surface antibody response, I would re-immunize them if they lose their surface antibody response. In the Q&A, we can certainly go into this. If they're hepatitis B infected, then you're going to want to retain one of the two types of tenofovir, TAF or TDF, or entecavir. And then this is the scenario presented, the isolated, the prior exposed individual. Here, I think overall, and this is largely based on some of the DHHS guidelines, if they are previously exposed, the reactivation rate is thought to be about 1% or less. And so I would monitor them. I'd monitor them with liver enzymes. I would monitor them sometimes with hepatitis B DNA, but I think it is okay to switch these people. I would vaccinate them first, but I wouldn't make their switching personally contingent on them having a surface antibody response. Of course, that's preferable, but I think, again, you explore with them, the risk tolerance and what the reason that they want to switch to cabrilpivirine, but that's what I would do. Let's take one comment and then we'll probably move on because
Yeah, I don't disagree with that, but I would mention that a couple flares that we've had in kind of my history in Colorado have been fatal. So even though something's uncommon, hepatitis B flare can be
sure
can be very serious.
And all the more reason to maybe even when you make the switch, monitor them at a month or two. Really keep track. This is not something to do lightly. I'm not going to go through this because I think you'll see some data on the durability of the CpG adjuvant vaccine, and I want to get to a couple other cases before we run out of time. So let me just triage here a little bit. What I'm going to do is take us to a case that is I think, very common in people's practice. So this is a 50-year-old woman with HIV. Her CD4 count is 500. Her viral load is 500,000. She doesn't have resistance, and she's got hypertension and gastroesophageal reflux disease. She started on bictegravir FTC TAF, and at week 12, her viral load has gone down to 100. But over the next year, her viral load just fluctuates between 50 to 100 copies. How many of you have people like this? Okay, I would say pretty much a majority of people. So what do you do? How do you manage her? Do you add a drug? Do you add doravirine to this person with viral loads between 50 to 200? Do you change your regimen? Maybe she's got resistance. Do you change it to a boosted PI? Do you evaluate her for drug-drug interactions? Or do you send a proviral resistance genotype? Let's see what you all do.
Boys, when you talk to boys,
The music is back.
to flirt and frown. I'll show you what shoes to wear, how to fix that hair. Everything that really counts to be popular. I'll help you be popular. So hang with our right.
I think Wicked Part 2 came out yesterday.
The slang you've
So-
got to know. So let's start, 'cause you've got an
Oh, the movie,
awfully
Wicked Part 2,
long way
the
to
movie.
go.
All right, so it looks like 60 of you have voted, and most of you are concerned about drug interactions, and about 10% want to send a resistance genotype, proviral genotype. What does our panel think?
I mean, I would say if this viral load was taken 15, 20 years ago, that would be below the level of detection. So I always struggle with having to explain to patients, what does low level viremia mean, and when are we concerned and when are we not concerned? I think of anything below 200 copies per ml as to be functionally undetectable, and that's how I explain it to patients, that you are functionally undetectable. I think the caveat there is if there's a trajectory of your 20 and then 74 and then 184, if there's some sort of trajectory that's concerning, that's when we might want to talk about things. But always evaluating for drug-drug interactions would be the first thing to make sure there's no absorption issue or metabolism issue.
And the drug interaction that you want to pay attention to here is bictegravir and the divalent cations. So calcium, magnesium, aluminum. And she had gastroesophageal reflux and maybe taking an antacid, which could be magnesium containing. I had a case like this recently on a guy, and I talked to him about all of this. Like, are you taking calcium? Are you taking magnesium? And then nothing, couldn't do it. So he came back the next visit and he goes, you know what? I've been using this zinc cream on me. And I'm wondering if I might be absorbing zinc. And he stopped it and his viral load came right down.
The other point, notably, this person had a viral load of 500,000 before they started treatment. So those people always take longer to get down and stay down. And so that would be something that would make me less concerned that this was really failure and more just time.
One of the things we've mentioned at previous conferences is just that kind of breakdown of virally infected cells as a cause of viremia. So I think there's a differential diagnosis: adherence, resistance, release from the reservoir, drug-drug interactions. And the other thing I'll mention, we had kind of a pseudo outbreak of viremia, one of the outreach clinics that I was involved with, and it was a phlebotomist that had switched tubes for a collection of viral load. And once we figured that out, the viremia went away.
Interesting. So Dr. Johnson just mentioned, and I would agree, the differential for these people who are not uncommon, between 20 to 200, people who 15 years ago when we were using viral load, 20 years ago when we used the viral load of less than 400, we couldn't even see. It could be adherence, always worthwhile to check pharmacy refills. Consider the drug interactions. It's not dietary multivalent chitins, it's these supplements: calcium, magnesium, iron, zinc is often used for bodybuilding. And I've had similar, not with the topical, I've not seen that before, but with people taking zinc supplements can affect the absorption of integrase inhibitors. Intercurrent illness, probably not. Those are usually transient. Malabsorption is really very, very rare. When I mean malabsorption, like the gut malabsorption. This was the last point that was made. There's several studies now from John Mellors, from John Lee, from Francisco Simonetti, showing that if you have some people with low-level viremia, you can see that their integration sites are not evolving. Essentially, they're spitting out virus, but it's not replicating because the integration sites stay stable. And this is probably more frequent when the reservoir is big to begin with, the point that Dr. Courier made. Long time ago, I did a study in the ACTG where we added antiretroviral therapy. We did intensification. This was not for this exact scenario, but there was no effect of intensifying, adding a fourth drug to reduce low-level viremia. So for this, I go through this differential every time, but I don't change medicines just for viral loads of 50 to 100. Proviral genotyping, this is when you're assessing not the RNA, but you're assessing the DNA for resistance mutations. The important point to remember here is that at least 90% of DNA proviruses are defective. That is, they're not replication competent. They have kind of mutations in them that make them not replicate. And then the test itself has both sensitivity and specificity issues. So in one study, they had 100 people who had an M184V, the signature mutation of 3TC. They had 100 people, and they had it because they had a historical genotype, an electronic record that said they had an M184V or some other demonstration. They did a proviral genotype. All of them were suppressed. Only half of the time could they find the M184V. So it's got a sensitivity problem. More recently, there was a longitudinal study done where they did sequential proviral genotypes, and half of the time the resistance mutations were variably detected. You found it one time, not another. And finally, it's not validated. So I have used it occasionally, and we can talk in the Q&A about when, but generally I tend not to use it or use it very cautiously. If you find a mutation, then we take it into account. If you don't detect it, it doesn't exclude resistance. I don't do this in someone who I'm switching to cabergoline, for example. If I have a decent history, or if they tell me and have reason to think that they've been suppressed on their initial regimen without virologic failure. And patients, I mean, sometimes you can't get the records despite what you do, but patients often do remember if they've been suppressed since they've started. And I usually will not do a proviral genotyping then. It's in someone who had virologic failure over and over again in the 90s, early 2000s, where they went off and off again, on again. You just can't get their records. That may be an instance, but even then, it's fraught. It's a fraught kind of situation. Okay, we have two more cases, and then I'm going to try to do a mystery case if I can get to it. I might eat a little bit into the Q&A because I think you'll enjoy this last case. But let's try to do these a little bit more quickly. So this is a common scenario. This is maybe the same person, hypertension. She started on bictegravir FTC TAF. Her viral load this time goes down to below 20 copies, but her weight goes up. Her weight goes from 60 kilograms to 75 kilograms. Her BMI, though, even at that weight, is 29. Her ASCVD is 6%. What would you do? Would you change your regimen to doravirine TAF FTC? Would you change your regimen to cobicistat boosted darunavir FTC TAF? Would you start a statin or would you start semaglutide? Go ahead and vote. Good. 70% want to start statin, 16% semaglutide, 10% change. What do people think? What does the panel think? Dr. Currier, weigh in first.
I think I would, she was a candidate for a statin before. Nothing about her weight gain changed her risk. So I think that is something easy. I think how you manage her weight gain is another issue, and the statin's not going to help you with that. Unfortunately, our attempts to find switches to other ART regimens as the solution to this have been really unsuccessful. And I'll let Tripp talk more about that because he was involved in the study that did it. I think it is, this is somebody who's premenopausal. It's probably quite concerning that this may affect her adherence. And so we do have to look at what she's doing in terms of diet and exercise, and also think about other interventions. The other one that I would look at her hemoglobin A1C as well and see whether she might be a candidate for metformin. But we don't have a good response to this, and it's a huge problem. So, but I'd let Tripp talk about.
Yeah. Why don't you tell us what we know, and then we'll.
So switching antiretrovirals in this case was an attractive strategy, but that's now been explored in prospective studies that looked at each of the regimens that we had choices on here. So both small studies, the DEFINE study took people who were on TAF and a modern integrase inhibitor like bictegravir and randomized them to switch to what you see there, FTC TAF and a boosted darunavir regimen, or continue on their regimen. And they saw no change in weight from switching to the protease inhibitor. And then ACTG 5391, which I was part of, did the other strategy that you see there, switching from bictegravir, dolutegravir, or raltegravir in combination with TAF and FTC to doravirine. And we had two arms. One was TAF FTC and the other was TDF FTC. And on that study, all three, or continue the integrase inhibitor, all three arms lost weight, but there were no differences between the three arms. And the interpretation there, which may help inform this case, is if people want to lose weight, they need to do the traditional things like diet and exercise. And Jiffy Pop, what?
GLP-1. I think Dr. Benson gets the last word, and then we'll.
Well, I was just going to comment on the GLP agonists. In our part of the world, the only people who can get that paid for are people who are already diabetic or have an elevated A1C. So just for weight loss, we couldn't prescribe that and have it paid for. So
obviously, this is rapidly evolving. These are the points that I've already made. I won't go back to them. She does have an indication for a statin based on the REPRIEVE study. Her ASCVD is 6%. These are the points that were already made about the DO-IT study. And so the bottom line is what you've heard already. You can't really give a talk these days without a one mention of GLP-1 receptor agonists. So there's two studies I want to just mention. One is done by the ACTG in people with metabolic associated steatotic liver disease, MASLD. It's called the SLIM liver study. I think one of the best names of a study that I've seen recently. And what they showed by giving in the single arm study semaglutide is that there was a 31% reduction in the triglycerides in the liver, and almost 30% had resolution of the MASLD. A separate study done by Grace McComsey and colleagues was a randomized study, placebo-controlled, for lipohypertrophy, HIV-associated lipohypertrophy. There was a reduction with semaglutide with abdominal and total body fat, but there was also a reduction in lean body mass. Both studies used the semaglutide dose that's lower than is given for diabetes or for weight loss. And there may be some concerns around lean body mass decrements in people with lipoatrophy. So right now, I do try to get these if people have diabetes or obesity. And for someone who doesn't have those, then I haven't been using it. Let's do this last case and we'll go out on this and then take your questions or
One more
comments.
point
Yeah,
about
yeah.
The
let's-
GLP-1 though.
Yeah.
I mean, I feel like there's a case to be made to get more data in people living with HIV if it can improve weight loss, but if it can also reduce cravings for things like alcohol and
Yeah.
drugs, and if it has any effect on dementia. I mean, there's this multifocal or multi-system broad spectrum effect of these drugs on many
Yeah.
different chronic diseases could be really a game changer for people living with HIV. So we really do need to know more about the safety, and when the oral formulations come out and the prices go down, maybe we'll have that opportunity.
Good point. Good point. All right, the last case, and I hope people have been keeping some questions because we will have some time for questions, and we can go back to some of the points that were made or explore new points. On the GLP-1 though, before leaving that, the DO-IT study that Dr. Gulick had led, that had a median duration of ART of about 3.5 years or so. And so one thing that I think is still an open question is there any impact if you give GLP-1s earlier, right after you start ART? I'm interested, maybe you can give your perspective on this, but a lot of the weight gain does occur in that first year of ART. So maybe you can give us your thoughts, Dr. Gulick, on that, and then we'll do this last case. Do you think earlier would be better?
We took a look at that
Yeah.
on the DO-IT study because
Yeah.
people came in varying degrees of time, and
Yeah.
we were looking for that and
Yeah,
didn't
didn't
find
see
a
it. Yeah.
relationship. But whether even earlier might be the right time to do it, we couldn't answer.
So last case, a middle-aged man, I went away from the 50-year-old man, middle-aged man with HIV, his CD4 count is over 500, his viral load has been less than 50 for many years on TAF, FTC, dolutegravir. So he presents with 3 to 4 days of abdominal pain and chest wall discomfort. He's admitted to another hospital for evaluation of the chest discomfort, and he's found to have a pulmonary nodule and rim-enhancing lesions in his liver. He had secondary syphilis several years ago. He was treated. He had a non-reactive RPR about 4 months prior to presentation. He has several sex partners, doesn't always use condoms. He has no known TB exposures. He lives in the southern US. He does travel throughout Central and South America for leisure. He's also been to Asia. He has 2 dogs. He has a cat. He does smoke cigarettes, about a pack a day. When I see him, he's afebrile. He's got no rash or adenopathy. He doesn't have any findings on abdominal exam. Importantly, though, his alkaline phosphatase is 695. His ALT is 119. His AST is 70. His bilirubin is mostly indirect. It's 2.5. And his liver enzymes had all been normal about 4 months prior to this visit. So this will be a little bit hard to see, but I'll try to point it out. I don't think there's a mouse. So if you take a look at his chest CT on the right, in his right lobe, you'll see a nodule, very peripheral, right up against the chest wall. And in the dark with a radiologist, there's several other nodules, but there's one that I think, and I hope you can see in that on the right side of his lung. Sorry, on his left side of his lung. Trust me, there's a small pulmonary nodule that looks real. Sorry, it's on his left side of his lung. In his liver, in the dark with the radiologist, there are several, it turns out to be 7 or 8 different hypoattenuated lesions, essentially liver lesions that are rim enhancing. So in this person, I'm not going to ask you to vote. Is this most likely a malignancy, syphilis, pileosis hepatis, which is a Bartonella infection, a fungal infection, or a mycobacterial infection?
Didn't have a fever.
Who's that, Febra? Who's that, Febra? I think people are thinking this one is taking a little longer to get to 50. All right, let's see what you think. Okay, So a very big spread, Peleosis and mycobacterial infection, fungal, malignancy, syphilis, everyone gets a vote. So what do you think?
I would say the LFT pattern is unique. So alk phos out of proportion to other LFTs is not something you commonly see with every pathogen. And that's typically like for the ID fellows in the room, like typically a red flag, like a buzzword for border view of thinking of a syphilitic hepatitis of alk phos out of proportion to other LFTs. I think with Bartonellosis, you will see elevated LFTs across the board. And I'm not aware of Bartonellosis causing lung lesions, at least that commonly. And then given his history, I think you need to think about common things being common and potentially a syphilis reinfection given his history of syphilis in the past.
Dr. Benson, you have something to add?
So to some degree, the answer to this might depend on where you are in the US.
He lives in the southern US, but
Exactly.
yeah.
So despite your comments about elevation of alk phos out of proportion to the liver transaminases, with mycobacterial infections, we actually see that fairly commonly. And where I live on the border with Mexico, the most common thing this would be in our part of the world would be MTB. We've also seen a fair number of Mycobacterium bovis infections from northern Mexico, and that behaves more like MTB. But and then when I used to live in the Midwest, you might say histoplasmosis would be a common diagnosis, with fungal infection being more common maybe in the Midwest. In our part of the country also, we see a lot of cocci, and rim-enhancing lesions in the liver and in the lung is quite common with cocci. And so that might be something we'd look at more carefully in our population.
Just to state the obvious, he doesn't have systemic symptoms, right? No fever, no night sweats, no weight loss. Being a good test taker here, you got to go with syphilis, right? He has a history of syphilis. I agree with Anu about that.
Yeah. I think that, I mean, this is a great exercise to think about the differential, but the good thing about medicine is you don't have to guess. You just need to get tissue. And, you know, the issue is figuring is what diagnostic tests would be most likely to yield it. You know, do you induce sputum for MTB, or do you just go right in and get some tissue from his lung or his liver?
How about an RPR?
They do that too. But that wouldn't rule
We'll
out.
know tomorrow.
Yeah.
And just a comment about the pulmonary nodules with syphilis, because I actually sent one of my patients for a CT scan for lung cancer, and I was called urgently by the radiologist saying that I had a patient with metastatic malignancy, and it was secondary syphilis, multiple pulmonary nodules like this. So, you know, obviously you're going to screen for that, but I agree with Dr. Benson that a lot of the mycobacterial and fungal infections that are infiltrative, you know, you see higher alk phos.
And I can't tell you how many cases of TB I have seen who are afebrile. So again, I don't, all bets are.
As the non-ID doctor up here, I will chastise you all for missing this patient's malignancy, causing his with bony metastases with an AST elevation. But your point is right. Like, we can figure it out.
All right. Okay, so I'll tell you what happened, because so I didn't know what it was. So I did blood cultures that were negative. His cryptococcal antigen was negative. His urine histoplasma antigen was negative. I did do serologic testing for Bartonella, Brucella, Coxiella, all were negative. His interferon gamma release assay was negative. He was still, HIV viral load was undetectable. His CD4 count was still strong. It was 500. His hepatitis testing was negative.
Okay, where's that RPR?
So wait. So what I did is, so I sent him for a liver biopsy, and I had a test that was pending. And so what happened is I got a phone call right as he was getting this needle stuck into his liver with the diagnostic test. But he was getting this, it was going in. I was like, do I do it? So he has the liver biopsy as I'm getting this phone call. The liver biopsy shows periportal inflammation and edema. There were some granulomas. The microbiologic stains were negative. And so the phone call that I was getting as he was having this liver biopsy was his RPR. And his RPR was 1 to 64. And as you'll recall, it was negative 4 months before. So I treated him with 3 weekly shots of IM penicillin. We can talk about why, or we can discuss. His alk phos declined from 695 to normal. His ALT declined from 119 to normal. And I did repeat imaging, and all of those pulmonary nodules and all of the liver nodules went away. So this is a case of syphilitic hepatitis. Liver enzyme abnormalities may occur during secondary syphilis. The alkaline phosphatase may be disproportionately elevated, but not always. In one case series, the median alk phos was in the 180s, but there was a broad range, including up to 1800. The median ALT was 105 with syphilitic hepatitis with a broad range. Liver enzymes do normalize, but it can take some time, some months. If you do pathology, you'll see what we saw, which is pericholangular inflammation, periportal hepatocyte necrosis. We did not see spirochetes on our patient's liver biopsy, and you don't always see them. And what was really puzzling, but it's been rarely reported, is that you can sometimes get hepatic gumma, like in his lung, presumably, that mimic cancer. So that was a case of syphilitic hepatitis. I'll leave you with what you heard earlier today around doxypep, but I will say every one of those considerations was in the differential, and I want to applaud you all for your discussion. So I'm going to take questions. These were some of the teaching points from today. And people with cryptococcal meningitis start ART 2 to 4 weeks after initiating antifungals and when the cryptococcus is under control during pregnancy. Finally, the 3 drug regimens have aligned with options for non-pregnant people with HIV and people with difficulty adhering to oral ART. Injectable cabrylpivirine may improve outcomes, but you have to conjoin it with intensive support. There are some new guidelines for hepatitis B screening and vaccination prior to switching off of tenofovir. There have been important advances in preventing comorbidities, including with a statin. Syphilis continues to be the great imitator. And I'm going to leave you with the fact that despite progress, we need to diagnose and treat HIV earlier, address inequitable access, and invest in research to advance care and end HIV. So that's it for today. Happy to take any comments or questions either for me or the panel. So.
I'm going to let you moderate your own Q&A.
Okay. Okay. In a person who, we're going to start with crypto, with a CD4 count of less than 50, who's asymptomatic and has a positive crypto test, can you manage that person as an outpatient? So what would you do, maybe Dr. Benson, positive crypto antigen, asymptomatic, what do you do next?
So it's still pretty rare to see that in the US, but I know my colleagues, particularly those from University of Minnesota, would say that you would use preemptive fluconazole.
Would you do an LP? Would you do an?
Yes, you do an LP first,
yeah,
and then if the LP is negative,
yeah,
then you do preemptive therapy.
So then, yeah, you if you can get an LP as an outpatient, you can get that LP. If they're negative, you can give oral fluconazole. They don't necessarily have to be admitted. I think the DHHS also has a guideline around some of the LFA titers. If it's above a certain titer, there's above 1 to 160 or something. You have to look it up, but something in that neighborhood, you get a bit more concerned about disseminated disease. But you can often manage these asymptomatic people with a negative LP with oral fluconazole as an outpatient. So.
Yeah, there was a study presented at CROI this past year on just what you said, that if the cryptococcal antigen titers are above 1 to 640, then you'd be more suspicious that this is incipient active disease that you need to treat more aggressively.
Yeah. The second question is just affirming that Impact 2040, which was planned to look at PK and safety of long-acting cabrylpivirine, has been withdrawn at this time. This was what we were mentioning before. Would you consider for a patient with rilpivirine resistance, cabotegravir plus lenacapavir without rilpivirine? Anyone done that?
I think there's been a good amount of real-world data. It's case series data that's been recently published out of UCSF, and I think there's another cohort. And then even here in Chicago, I think Cook County actually has a good number of folks who are on Cablen and showing it to be effective. I think it goes back to sort of this idea of trying these untraditional regimens, and particularly when folks are in dire straits, and it works, an all injection regimen. So we've used it in multiple folks, and I know it's technically off guidelines or off of not FDA approved, but there is success with it in the right patient.
Yeah, I have one patient on cabotegravir, lenacapavir, who has NNRTI resistance. A question about pregnancy. Here the question is, we often talk about viral load impacts, but say a word about teratogenicity or fetal effects. Dr. Curry, comments on teratogenicity, fetal effects?
Yeah, I mean, I think that's what the pregnancy registry, really has been trying to do, is look at the rates of those and have people report exposures to add to that data. So I think the data that you shared about bictegravir was PK, but I believe there's data in the registry as well. And I don't know the last time that was updated, but it is a really good point. It's not just about viral suppression, it's about safety.
And I think Dr. Gould may know, but the DHHS panel that focuses on perinatal transmission, they want to see a certain number of pregnancy outcomes in people with the drug, and they got to that threshold. I think it's in the 400 range or something like that. But yeah.
The data are very reassuring that there is not an increased signal of teratogenicity with any of the antiretroviral drugs.
So this is a question that I'll take. Why did I treat the last patient with 3 doses of penicillin rather than 1? And is that your question? No, or you had this? Okay. So early syphilis, primary, secondary syphilis, can be treated with 1 dose and should be treated with 1 dose of benzathine penicillin. But this was an unusual case. Let's just put it out there. I mean, liver lesions and lung lesions. So I thought, why not give a little bit more penicillin, give 3 shots rather than 1? Because this is not something, even though it's been seen, it's not something you see every day. So that's why I gave 3 doses.
That's nice that you have bicillin in Boston.
Yeah.
If you're not having it anywhere else.
This is a few years ago, actually, so may not be able to do that now. Please, why don't you go next?
I recently had 2 patients with persistent low-level viremia between 200 and 300. Occasionally goes down to like 150, but it's like, so what? Yeah, what do I do? I mean, I went through your whole list with the drug interactions and all of that, and
so adherence, as best you can tell, with pharmacy refills, okay. No other drug interactions that you've kind of gone through all of that. I mean, I would probably do the topical zinc thing to make sure that that they're not doing that. So
the issue is, I mean, trying to get people to bring in everything they're taking, because some things they don't consider to be medication sometimes. And this thing I got at the gym, that's what happened to me one time. This person was taking some magnesium supplement that he got at the gym, but he didn't think that was medication. And that turned out to be the culprit.
So when all is said and done, if I can't find anything, these studies that have looked, and this is one of the questions, what does it mean to say integration sites are stable? So the higher it gets, the more worried you get. So around 200, 100, especially, if you go through all of that, like I did with my patient, and there's still a viral load of 100, I'm less worried. If there are 400, I would be more worried. If there's somewhere in between, sometimes it's impossible to tell. I have a patient who's been between 100 to 150 for about 15 years now, and he just stays in that range. What they did is they looked at, normally when you get a new viral infection, the integration site for a new infection is not going to be the same as for a previous infection, because every time HIV replicates, it goes and integrates into a new place. And so these studies that looked at the so-called proviral landscape, they were able to show that there was no evolution of integration site. And this is not a clinical test. This is clearly a research test. So that was one of the questions online. I think I would go back and do what was said, anything you put in or on your body, bring it in, and let's make sure that there's not something going on there. But when all is said and done, I don't think I would change his regimen. I wouldn't add a drug. I wouldn't subtract the drug, and I wouldn't change. I would do all of those other things first and monitor, as I'm sure you're doing. So,
Raj, in that situation, would you get a proviral for this type of like a viremia 300, 200, 300?
I probably would.
Could you get, did you
My
get a
question is
regular
a plasma
genotype?
genotype.
Yeah, sometimes
Yeah.
you can get a research genotype.
What did the genotype show?
Well, of course, the time I tried to get a genotype, it went down to like 150.
Okay.
I didn't get it, but I think I
So just keep
have,
ordering genotypes.
I
Just
have
get-
gotten, the genotypes, all, the ones I have gotten are all fine.
Wild
Yeah.
type.
Yeah.
So
Well,
you just have to accept that this is his set point
So
and that
you-
he's going to be stable. and-
Dr. Barr is going to comment. She's right behind you, and then there, you can certainly also comment. One thing to remind people though is that it's not dietary multivalent calcium. You can drink milk with your bictegravir FTC TAF. That amount of calcium is not the issue. It's the supplemental stuff. That's what does it. But Dr. Barr.
I keep asking people about their cation intake and they don't know what I'm talking about. So ask brand names. Don't just ask about diets and supplements. Ask specific brand names.
Yes, exactly. Yeah.
Yeah, I think all these comments about nutritional, dietary, vitamin supplements are really valuable because there's an insane new world of people taking things that are not considered medicines to them that really do interfere with absorption. That being said, I think this is a nice intersection of cure and therapy because we have a lot more knowledge from studying the reservoir about how people who previously have been quite stable and undetectable on their antiretrovirals can start to have increasing amounts of low-level viremia. And it can even pass these thresholds that Dr. Gandhi speaks about being sort of comfortable with, under 100, under 150. And that's because as we get older, these infected clones of viruses can expand and can become quite reactivatable. And so there's no new infection events. Your virus is still nicely suppressed, but these expanded clones can be, in some individuals, active and they can spit out more virus over time. And so you can see someone who was quite stable, suppressed for years, sort of climbing into the detectable range and even a little bit higher. And so if it gets higher and higher, you're more concerned about poor adherence. But this is a pattern of sort of expansion of these clonal populations, some of which can have more virus that they're spitting out. And therefore, this is something that we just have to be comfortable with as providers. And maybe you can just give them a few extra doses of bacillin and, and everybody will be comfortable.
It's always the answer. Okay, I think I've exceeded my allotted time, so we're going to leave it there. There are a few other questions. Sorry we didn't get to all of them. Thank you for your attention and thank you for our panelists.